We record our sessions so that we can make them available on our website after the fact for folks who might have missed the session or who want to revisit it. So I'm just going to quickly go over the functionality of WebEx webinars in case anyone's unfamiliar. Firstly, you can turn on closed captioning by clicking the CC button at the bottom left-hand corner of your screen if you wish to do that. You can also change the layout of what you're seeing by clicking the layout at the top right-hand corner of your screen. And you can raise your hand or do a thumbs up by clicking either the hand or smiley face buttons at the bottom center of your screen. But please note that you can't unmute yourself. So if you have a question that you'd prefer to speak out loud, you can raise your hand and I can unmute you. And finally, you can access the chat at the bottom right-hand corner of your screen, and there will be an opportunity for questions at the end of the presentation. So please feel free to use the chat to pose those questions, and I'll continue to monitor that as we go through the session. And with that, I think I'll turn it over to Marie Chandel.
Thank you, Chelsea, and thank you for welcoming us today. Before getting started, I would like to first respectfully acknowledge the land in which I'm presenting from today, which is the traditional territories of the Wendat, Anishinaabeg Nation, Haudenosaunee Confederacy, and the treaty lands and territories of the Mississaugas of the Credit, and recognize that this land is now the territory and home of many diverse First Nation, Inuit, and Métis people. And I'd like to also extend this acknowledgement to the lands where each of you are joining us from today. And I invite you to type into the chat your own land acknowledgement and sharing that with the group today. So like Chelsea mentioned, I'll be co-presenting with Julia Bird today. And so I think we'll just get started on the overview of our session. So today we'll start by introducing the concepts of health and health-related data, just to sort of set the stage of how this is important for the work that Juliana, myself, and our network is undertaking. And then I'll provide a brief overview of HDRN Canada and the DASH service. And then we'll share how HDRN is also engaging with members of the public through its Public Advisory Council and other projects being undertaken through the Advisory Council itself. Okay, so what are health data? I'm sure many of you, most of you on the call are already familiar, but again, more just to set the stage. HDRN Canada describes health data as information about the health services that people receive. So this, is information that is routinely collected during interactions with the healthcare system. For example, visiting the emergency room, seeing a family doctor, or receiving a prescription for a medication. And often this data is identifiable, so it can identify individuals with name, personal information, address. And this information is really helpful to providing care, personalizing treatment, and for continuity of care between healthcare providers. And we're increasingly seeing a number of initiatives from the government, hospitals, and companies focus on giving people access to their own health data and personal health record because people are really starting to understand the value of health data in their own care. And that will also touch on some of the points that Julia will cover later on in the session. There's also other types of data that aren't specifically collected in the health and medical system, but are very much interrelated. So these health-related data or social determinants of health include sort of broader range of personal, social, economic, and environmental factors that determine individual and population health, such as language, income, immigration status, and education level. And then these type of data can then be linked with health data to give us a more complex understanding of the healthcare system and health outcomes. So next slide. So as I mentioned, people are starting to understand the importance of having access to their health data to stay informed about their own health care. And this data is also very valuable to researchers as well, who want to use and access this data to better understand disease, treatment, and how the healthcare system functions. However, in Canada, as many of you know, healthcare and social services are delivered provincially. So each province has their own healthcare system, and often most health research is conducted in single provinces. So it can be difficult to learn from the different approaches that provinces are using to solve health problems, even if trying to look at similar types of data. And this is really where HDRN Canada comes in. So we are a pan-Canadian network of organizations who are working together to help researchers conduct multi-jurisdictional research. So this is really important because when researchers have access to data from multiple provinces and territories, it's easier to conduct new research on topics that can affect us all. So this could be things such as wait times and related to areas such as mental health and chronic illness. So HDRN Canada is made up of member organizations, which includes SPORE support units, universities, research institutions, and we have some of our member organizations listed here on the slide. And HDRN Canada is funded by the Strategy for Patient-Oriented Research, or SPORE. And this is an initiative from the Canadian Institute for Health Research, so CIHR, which really focuses on transforming patients and their families from passive recipients of health services into proactive partners who can help shape research and healthcare. A few important points to note about our network. So HDRN Canada does not hold data. The data that can be accessed and that we're referring to in our presentation today are held by our member organizations or data centers. Researchers, when accessing data, for the most part, are accessing de-identified data through these organizations or data centers. So HDRN is really acting as a facilitator. So each of our network organizations receive data from multiple health sources, would play a role in linking different types of data together, removing identifiable information, and then this information would be made available to researchers under very specific provisioning. And I'll touch a little bit more on this over the next few slides. So the Data Access Support Hub, also known as DASH, is a service that was developed through HDRN Canada for researchers who want to access multi-regional data from two or more of its member organizations. So there are 13 organizations from across Canada that are part of DASH and work together to support data requests. So these include provincial and territorial data centers, such as POP Data in BC, ICS in Ontario, and NILCHI in Newfoundland, as well as pan-Canadian organizations such as CIHI and Statistics Canada. So DASH's role is really to coordinate and facilitate discussions between the researchers and data centers to make the data access journey and process more efficient and easier for a researcher. As part of our work, we continue to follow region-specific legislation and policies when it comes to data access and release. So since the launch of DASH in 2020, we've developed as a group some streamlined processes to provide better support and coordination for researchers who are accessing multi-regional data. As part of this, we've developed resources and tools, which I'll touch on later in the presentation. And over time, these solutions will help further streamline and automate the data access process. So next slide. So like I mentioned, Dash's role is really in a facilitator role in terms of helping researchers have a coordinated and single path from the initial sort of data inquiry through to data access request, review and approval, and then provisioning of the multi-regional data. So the diagram here outlines at a high level the main steps that are involved in the request process when coming through Dash. And I'll just quickly walk you through some of these steps. So in the first stage one, a member of the research team would submit a central intake form to our team through our website portal. And after receiving this form, Dash would consult with the researcher to review their needs before having the project reviewed by the representatives from the individual data centers to provide initial sort of review feedback and really help sort of refine the researchers' queries and proposals as needed and make sure that the project is well formed to proceed to the next stages. Our sites would, as part of this review, confirm eligibility and feasibility of the project and develop cost estimates. Once a project is deemed feasible, the researchers have confirmed that they have funding to proceed, the project would then move forward to the stage 2, which is the more formal data access request stage. So in this second stage, researchers would complete a central Dash data access request through our portal. And then we would help coordinate the review of the data access request. And locally, sites would then support the researchers to obtain the necessary approvals, as well as the drafting of any agreements that are needed between the researcher and the data centers, prepare the data, and enable the data access locally. Some centers also offer analytical services. In terms of some of the timelines to complete these activities, each stage, I can say, can vary quite a bit due to a number of factors related to the complexity of some of the projects. So for example, data linkages are needed, or if researchers are bringing in external data data sets for linkage, if additional agreements because of the sources of data are needed, can add some time in complexity. But once we've reviewed a project, we would be able to be in a better position to provide researchers with estimates for their specific project. And then in terms of the third stage, once all of these stage 2 steps are completed, researchers would be then able to access data as per the local data center policies, and then be invoiced according to the cost recovery process of individual centers. In terms of the cost for accessing data, our coordination costs through Dash are provided at no cost due to the funding that we have through CIHR. However, most data centers have established cost recovery based fees for public sector researchers. And again, these costs can vary depending on the nature of the services requested. So if analytical services are needed, that may increase costs as well as the number of sites involved. And there is some information on our website about costs, but as part of the review process, we'd be able to provide researchers with a cost estimate for their specific project. So next slide. In terms of some of the data assets that are available through Dash, so this would include some administrative data, clinical data sets, such as data from electronic medical records where available, some social data, as well as new data sources that are continuously being updated on an basis, really based on some of the local centers' data acquisition plans. And HDRN Canada is also working closely with data centers to support new data acquisition. So for example, we're partnering with groups such as the Canadian Partnership for Tomorrow's Health, or CanPath, and the Canadian Longitudinal Study for Aging, or CLSA, to bring in their cohort data into provincial data centers where that is not yet in place, to make linkage to those data assets easier. And so the data asset inventory is a resource on our website that is available to browse, which really provides an overview of the data holdings that are available. So these are data assets that are available through the individual partner data centers and can be requested through us. So DASH has developed a number of resources within our network to assist researchers in the initial development of their project. So I mentioned the data asset inventory, and on the screen here is really just an example of what the inventory looks like. It has the ability to search by keyword. You can refine by region or by site, as well as by data categories. So just on the figure here, it's an example using the keyword laboratory, and as a result, there's a list of 9 data assets that have been tagged in the inventory using this term. So this is really a great resource for a researcher as well as the public to kind of see what data is available, especially when developing a research project. The algorithm inventory is another resource on our website, which includes information from systematic reviews that have been done to identify published algorithms for population health, health service use, and determinants of health. And all of the algorithms included in this inventory have been validated or tested for feasibility of implementation in 2 or more Canadian provinces and territories, or nationally. So really relevant to the Canadian context, and another great resource for researchers to browse. We also have information on our website around privacy, ethics, and some study design considerations for researchers, again, that can be helpful in the early thinking and development of a research project. It includes information on the availability of specific types of information around health data and its usage in privacy legislation. So for example, there's some content as well around advice when it comes to disclosure of personal health information and de-identified data. There's also information on our website around local data access processes and how these, differ slightly across provinces or data centers, and if there are any specific requirements, as well as the services offered in our member organizations. So we certainly encourage, researchers to browse these resources, especially before coming to DASH. So since the launch of DASH, we've been supporting several projects and soliciting feedback from researchers through an interim survey to make sure we're meeting needs and are able to really refine our processes, based on the feedback and needs of our stakeholders. Since launch, we've received some positive feedback from researchers who have been using our services so far. In particular, researchers have found the intake meetings that we have and the feasibility feedback from DASH in those early stages to really be helpful in order for them to, for that to sort of inform, not just the data availability, but as well as any sort of refinements that need to be made to their project. So for example, sometimes we might have researchers who want to pool data in a central location or want to move data out of province where that isn't possible because of, the legislation. So we'll provide some input into, what is possible, what the options are in terms of the data flow. And that can help refine, the proposal and make the project feasible. Another, I think advantage of a DASH is really also the ability to quickly bring together the partners from the various organizations and data centers and helping researchers identify, which institutions have, the data that they need and, have the right people at the table to provide input in a quick way. So on this slide here, I've just summarized for those on the call who might be interested in working with DASH, or if you have any stakeholders that may be interested in accessing data from multiple regions. The process is fairly simple to start. So you would be registering for a DASH portal account on our website. And then from there, you'll have the ability to submit an intake form. The intake form would ask some basic project information, such as, the project title, the objectives, the type of data that you're looking to access, from which, sites or region, if there's specific services you're looking for. So if you're looking for analytical services or specific software, those are all things that we would capture through the intake, so that we can, provide a fulsome review. Once we've received the intake form, we would schedule an intake meeting with yourself or with the research team in our partner centers to answer any sort of preliminary questions, to refine, the intake and the proposal if needed. Once that has been done, then DASH can complete the review of the proposal, and usually that takes around 2 to 4 weeks, depending whether there's, missing information or if we need to have a little bit more back and forth in terms of refining some of the, the objectives or the data requirements. But what DASH can do is we can, provide some feedback on your proposal, provide some essentially some feasibility feedback. We can provide cost estimates to support researchers in their grant applications. And we can also provide an HDRN letter of support if needed for your grant applications. And then, so these are really sort of the initial steps. And then from there, if you have funding in place and if you're ready to proceed, with a formal data request, at that time, we would provide additional guidance and instructions on how to proceed with the formal DASH data access request. So there might be some additional sort of steps, approvals needed locally. For example, most of our data centers would require ethics approval be in place locally. So we would provide some guidance around what is needed in the different sites that are involved in the project. And again, the timelines, are a bit variable depending on really the readiness of researchers to proceed. So just on the next slide here, and sort of to conclude the DASH portion of the presentation, I wanted to share just some tips for a successful application based on our experience to date. So I've mentioned a number of resources, so we would encourage researchers to, review some of the information on our website so that it can be considered in the initial, proposal. Also, it's important to be familiar with the legislation or policy for disclosure of patient-level data, and to the transfer and sharing of data across regional boundaries for research use. Sometimes, proposals are coming to us where, there is a complex plan for how researchers would want to move data in a central location. Sometimes that isn't possible. So it then requires more work to sort of look at alternate options, but we're always there to support those discussions and options. Another piece as well is ensuring as a researcher that there is appropriate authority or consent to link researcher collected or external data. So if you as a researcher are collecting data, could be a clinical trial or survey, and you're looking to link that data to administrative data, we would need to make sure that there's appropriate consent, that the language in the consent form allows for the disclosure and linkage of the data. So again, there is a few guidance documents on our website that provides overarching sort of guidance, as well as some site and local guidance. So for example, BC has some, very specific language that they would need to have included in any consent forms for the BC population. So these are really important things to think ahead in the development. Otherwise, it might require reconsenting of patients, or in some cases, maybe, the option to link wouldn't be there. So, an important consideration as well. Having well-defined study objectives and data needs upfront can help, improve on sort of turnaround times. When researchers come to us knowing exactly what they want, we're able to provide, input and review the project more quickly. But again, we really invite researchers to come to us as early as possible. That way, we're able to provide guidance and options that are available in terms of your data needs and data flows, and what's possible to access data from a number of organizations. So this concludes my portion of the presentation. So I will turn it over to Julia, who's going to speak about how HDRN Canada engages with the public.
Thank you, Marie-Chantal, for that overview of HDRN Canada, as well as talking about the DASH service. So as Marie-Chantal mentioned, I'll talk a little bit about how HDRN Canada engages with the public. So as mentioned previously, HDRN Canada is supported by funding under CIHR's Strategy for Patient-Oriented Research, or we call it SPORE. So this means that patient and public engagement is really an important component of our strategic plan. Now, we choose to use the terms public instead of patient, and public engagement instead of patient engagement, to emphasize that the data that's available through HDRN Canada member organizations extend beyond interactions just with the healthcare system, and it affects family members, care partners, and the broader community. I've been in many conversations where people have debated the right term to use, and especially when we're talking about patients or members of the public who are involved in health research, they often identify in different ways. Some may identify as patients, others as people with lived experience. So we won't get into that today, but just a note that we do tend to use the term public and the term public engagement. So again, as an initiative of SPORE, we commit to engaging with the public in a way that is continuous, substantial, and meaningful. So how do we go about this? Next slide, Chelsea. Thanks. So to ensure that we are accountable to meaningful public engagement, and also to ensure that we have a way to evaluate our public engagement efforts, we recently developed HDRN Canada's first public engagement plan. So what you'll see here on the slide is a modified, slightly higher level scope of the plan with some example work streams. In defining the scope, we really wanted it to complement and not duplicate the work of other SPORE entities and other health systems initiatives that already have a public or patient engagement focus. So to help with this, we conducted a survey of all of the HDRN Canada member organizations, as well as other SPORE entities. And this survey really formed the basis for these different work streams that you'll see here. I won't go through all of them in detail. The first one, of course, is the Public Advisory Council, which I will talk about in more detail in a couple of slides. We do have a public engagement working group, and this group was really established to develop and deliver our public engagement plan. And the group works quite closely with the Public Advisory Council and is made up of members from HDRN Canada member organizations who have experience in public and patient engagement. Workstream C there is public-oriented communications, and you'll see communications come up as a theme throughout this talk about public engagement, just because our Public Advisory Council has felt that communicating with the public about what HDRN Canada does and the importance of data-intensive health research is quite important. So that's something that's been a focus of our public engagement efforts over the past couple of years. I will point out the work stream that's focused on knowledge sharing across public and patient councils and committees, just because I'd like to put in a little plug that we are planning for our first knowledge sharing event that's happening this April, and it's called Health Data for All of Us, Sharing Ideas and Priorities. And the goal of this event is really to bring together key stakeholders in the health data and public engagement space to give them a forum to share work and have dialogue. So the event will actually be in person in Winnipeg as well as online. So if you'd like more information, feel free to reach out to me or keep an eye out on HDRN Canada's social media channels. I'll also mention another work stream is projects with a health data and public engagement focus. So these projects can be internal or led by HDRN Canada or in partnership or contributing to external projects. And oftentimes members of our Public Advisory Council are involved in these projects, as well as other members of the public outside of our council. Of course, evaluation is an important component, and our evaluation really depends on the specific work stream. So we do have project-specific evaluation, and the Public Advisory Council, as well as the Public Engagement Working Group, have their own evaluation process. So for the rest of this presentation, I'm going to focus on just a couple of aspects that you see here, one being the Public Advisory Council, and then I'm going to highlight a couple of projects that we've been working on over the past little while. So a little bit about the Public Advisory Council, or we like to call it the PAC or the PAC. So HDRN Canada does have a very active Public Advisory Council, and it was established in 2019 when an interim council was established, and this group was really responsible for drafting the group's terms of reference and helping to recruit for the first full PAC. As per the group's terms of reference, the purpose of the PAC is to advise HDRN on how to best communicate with the public, to advise them about its priorities, to identify issues that are important to the public, and to identify and discuss new kinds of data that HDRN Canada member organizations may consider collecting. For example, you may have heard of patient-reported outcome and experience measures, or PROMs and PREMs. These are some types of data that many members of the public are quite interested in learning more about and have been collected. So the PAC is made up of 12 to 15 individuals, and I believe right now we do have 15 people. And it aims to really be reflective of the Canadian adult population in terms of geography, sex and gender, age, ethnicity, a variety of different factors. The terms of reference also outline some key requirements that we have for PAC membership to ensure that it does broadly reflect the Canadian population. So we like to have at least 3 Francophone members and 1 residing outside of Quebec. We like to have 2 Indigenous members, and at least half we feel shouldn't have previous experience as a patient or public partner. The other thing is we tend to not want to have people who have too much experience in the areas of health data or data privacy, because we find that oftentimes this makes other members inclined, either consciously or not, to defer to them during discussions, so it can make the discussions during the meetings a little bit imbalanced. We do also, or the group does strive to adhere to the principles of IDEA, so inclusion, diversity, equity, and accessibility as well throughout all of its operations. For example, through ensuring recruitment reaches diverse populations, for ensuring that they're hosting accessible meetings. So for example, providing assistance with technology, providing media materials in accessible formats, having French English interpretation services. HDRN Canada does have an IDEA team who we work quite closely with to ensure that we are adhering to these principles as best we can. So I've outlined here just some of the many activities that PAC members have been involved in, as well as the different types of advice provided by PAC members over the last 2-3 years. In terms of the advice provided, they have provided feedback on the HDRN Canada strategic plan. So things like suggesting to use more accessible and plain language, defining certain terms, adding more detail about topics they felt were important, like their commitment or HDRN Canada's commitment to privacy, for example. As I've mentioned, they've also identified communications as a priority for HDRN Canada. So how can we as a network communicate clearly with the public about what we do? What types of data do our member organizations hold? What is the benefit to members of the public for this type of network to exist? Those sorts of questions have been raised by numerous members of our council. The PAC has also established a couple of interest groups that are comprised of a subset of PAC members who are interested in providing ongoing recommendations to HDRN Canada about a range of issues. So currently we have 2 interest groups ongoing that are focused on communications as well as IDEA. PAC members are also involved in many projects, as I mentioned, that are led by HDRN Canada or in partnership with HDRN Canada that have a public engagement focus. So that's a good segue to talk about a couple of the projects that we've been involved in a little bit more detail. So the first project that I'd like to touch on is the Social License for Uses of Health Data report. And this project was funded by the Public Health Agency of Canada to inform their pan-Canadian health data strategy. The main idea here is that members of the public see health data as an asset that should be used for public benefit, but their support is conditional. So there are certain requirements that need to be in place for a use or a user of health data to be socially acceptable. For example, requirements related to equity or privacy. The term social license is a bit of an interesting one. I'd never heard of it until I got involved in this project, but in plain language terms, social license is kind of an informal agreement between stakeholders or the public and organizations for an organization to do a certain type of work. So it's possible for an activity to be legally allowed, but outside of social license. Traditionally, the term has actually been used in the mining industry, but increasingly we're seeing it being used to describe which data-related activities have the support of members of the public and under what conditions. So if we say that a use or a user of health data is within social license, we mean that it's a use or user that is at minimum publicly acceptable, and ideally it's a use or user that has active public support. So this project synthesized input from over 30 experienced public and patient advisors, and we were really looking to learn about 2 main things. One being essential requirements for a use or user of health data to be within social license, and 2 specific examples of health data uses that participants agreed were within or outside of social license. So for some context and to give you an example, a requirement for social license could be that there is transparent and plain language about how health data are used. An example of a use of health data that people could think would be within social license could be something like it is within social license for health data to be used by academic researchers to better understand health and well-being. So I wanted to touch on just a few key points about the public engagement and the methodology of the project, because I think it was quite an effective way to gather input from a very diverse group. So we had groups of people convene on 2 separate occasions to discuss these requirements or essential requirements for health data social license, and to discuss and hopefully come to consensus on examples of health data uses and users that they felt were within or not within social license. So to help the group come to consensus on these examples, we used what is called the 5-finger facilitation method. So in this method, the facilitators would present a statement like the one I just provided a few minutes ago. So something like, it is within social license for health data to be used by university-based researchers to understand disease and well-being. And then participants would show how much they supported the statement by using their fingers. So 5 fingers would be full support, and a fist or 0 fingers would be complete opposition. And then the facilitators would ask 1 or 2 people who strongly supported the statement and a couple people who strongly opposed the statement to speak about their reasoning behind it. And then oftentimes that would lead to some wording changes, and then we would vote again to see if the group would come to consensus. And we would deem it to be consensus if no one had a closed fist. The other aspect of the methodology that I did want to touch on briefly was the inclusive design of the process. So The paper identifies but doesn't focus exclusively on the views and requirements that were supported by many participants. It also highlights views and requirements that were supported by just one or two participants. And we took this approach really because we know that people who hold minority views are least likely to be served by the status quo. But often these views are essential for policies and procedures that work for the entire population, not just the majority. And we also felt that including these views would be helpful because they were probably less likely to be reflected in the current literature about social acceptability of health data use. So just to give an example, a minority view that came up during the discussions that is mentioned in the report that came up from just a very small number of participants was that health data controls, safeguards, and regulations should be proportionate and not so burdensome that they prevent benefits from being obtained from health data, compared to the majority of people who were involved, who were very focused on, ensuring proper security and controls to prevent privacy breaches. So kind of two ends of the spectrum there. I do want to acknowledge that this approach, the inclusive design approach, was very much inspired and informed by the work of Yuta Trevorianis, who is the director of the Inclusive Design Research Center at Ryerson University. So just in terms of the findings of what we found after all of this process, so one part of this project, as I mentioned, was having the participants or the members of the public discuss essential requirements for health data social license. So I've listed some of the essential requirements that we found here on the slide. And as you can see, they were categorized into a number of different categories. So benefits, commercial organizations, etc. A lot of the discussion, I would say, focused on plain language about health data use by commercial organizations, related to this as well, the selling of health data, and of course, personal control over one's own data. The original goal of the project was to come up with a kind of a small, concise list of requirements that all participants agreed were essential. But instead, surprisingly, our list of requirements kept growing and growing. So we ended up with a list of requirements, over 80 requirements, and every single requirement was identified by at least one participant as essential. So I think that really reflects kind of the diversity of the group and the complexity of this topic. And then in terms of that second aspect of the project, so trying to come to consensus on uses of health data that people felt were within and not within social license. So the group did agree on 3 examples or users of health data that they felt were within social license. So you'll see there healthcare practitioners to directly improve the healthcare decisions and services provided to a patient, by governments, healthcare facilities, and health system administrators to understand and improve healthcare and the healthcare system, and by university-based researchers, which I've already given that example. They also came to consensus on 2 examples that they felt were not within social license. So one for an individual or organization to sell or resell someone else's identified health data, and 2 for health data to be used for a purpose that has no patient, public, or societal benefit. Interestingly, the group did not come to consensus on uses of health data about systemically marginalized populations or about companies using health data. I will note that the full report is available on the HDRN Canada website, and we have the link on the last slide of this presentation. And a number of other knowledge translation and mobilization products have been produced or are underway, including plain language articles, presentations at conferences, etc. We're also in the middle of putting together a second paper, which includes an evaluation of the process by the members of the public who participated in the project. And for this, we did use the McMaster Public and Patient Engagement Evaluation Tool, which some of you may be familiar with. And the last project I will touch on, which not as much detail because we are still in the beginning stages of it, but we have talked a little bit about plain language about data. So this brings us nicely to this project, which is the Plain Language About Data project, or we like to call it PLAD. The main idea of this project is really that members of the public care about how their data are being used. However, it is often difficult for people to understand what's happening with the data that is collected about them. Now, this is not limited just to health data. So if you think about visiting a certain website where you have to input your information, You'll often get a prompt to accept the organization's privacy policy, and this is often a very long document full of jargon that nobody reads. So we believe it is important for organizations to be transparent in their communications about data collection, use, sharing, reuse, by presenting plain language communications that are tailored to an individual's needs as well as preferences. So I like the quote there in green on the slide. You can't have trust without transparency, and you can't have transparency without plain language. So this really reflects this notion of the public trust in health data use, and that plain language at its core is really essential for public trust. This is a research study, so the team is made up of over 40 people from a number of different countries. It is international, and the team does include many members of the public who helped to co-create the study design and methodology. And the main objective of the study is really to learn more about what people want to know about how their data are being used. So there's 2 stages. The first is a series of virtual generative dialogues. So we hope to convene groups of people to discuss what they want to know about how their data are being used. And what we want to come out of that is a personal data notice. So what I mean by that is when you do give your data to an organization, what do you want them to tell you? For example, who's accessing your data? What is it being used for? What data are they collecting? How long will they have it? Will they sell it to a third party? All those sorts of things that I'm sure we've all wondered in the past. Stage 2 will involve a greater number of people, and it will take all of those bullet points of information that were generated during the dialogues, and we're using a Delphi method. We'll have these participants kind of construct and refine their own personal data notice using an online survey or another accessible format. And we hope that we'll use some of these example personal data notices in the manuscript for the paper and other knowledge translation and mobilization products. We also hope that these example personal data notices will actually be used as templates for organizations who are collecting people's data. So if you are interested in learning more about any of the projects that I talked about, or HDRN Canada's Public Advisory Council or public engagement strategy in general, please feel free to reach out to me. And I think that brings us to the last slide. So thank you again for taking the time to speak with us today. You see some links there on the slide, some email addresses for DASH as well as HDRN Canada, the websites for DASH and the Public Advisory Council, and there is the link to the social license for users of health data, which I think I also just saw in the chat as well. Thanks, everyone. I'll pass it back to Chelsea.
Thank you, Julia, and thank you, Marie Chantal. That was extremely informative, and I have a few questions myself, but I'll turn it over, I guess, to our audience to see if anyone has any questions. And just a reminder that you can type your question into the chat in the bottom right-hand corner of your screen, or if you prefer to speak your question, just raise your hand and I'll unmute you. Well, why don't I start then? I have a question about the Public Advisory Council and whether they have any role in that intake process with the Data Access Support Hub.
No, they don't.
I just thought when Marie Chantal was talking about, maybe it's not appropriate because I know you're looking at the feasibility of projects based on, centers, different policies and things like that. But I just saw a great opportunity there where there will be some refinement of a protocol, refinement of a project for some public input.
That's a really good point, Chelsea. And we're always looking for ways to ensure that public engagement is kind of represented throughout all of HDRN Canada's operations. And again, the Public Advisory Council is relatively new, so we're still trying to find our footing in terms of how they're going to work and types of advice they provide and what they do for HDRN Canada. So Marie Chantal, I don't know if you have anything to add to that.
Yeah, so I think, like Julia said, the PAC doesn't have sort of a formal role in sort of the review or input on like individual projects. We do have questions embedded both in our intake form, as well as sort of the formal DAR, which really meets some of the local requirements in terms of the benefits to the public or to patients. So there are questions that researchers have to sort of answer and provide rationale, and that is sort of part of the local review to make sure that, you know, what is kind of articulated really is, you know, sufficient and meets, you know, the needs. But, you know, I think there could be an opportunity to kind of see how we can bulk that up from almost an HDRN perspective. There's been also some discussions with the idea then our idea sort of team to see how we could also embed additional sort of idea criteria perhaps as part of our intake process. You know, we ask questions around whether, you know, researchers are, for example, going to be using or requesting any data related to First Nation Inuit Métis populations, again, so that we're making sure that the right groups are being consulted and engaged as per local processes. So in some provinces, that might mean having somebody from, you know, one of the first FNIM communities be part of the research team. And so to ensure those projects are Indigenous led. In some other, you know, regions, this might mean they might need to go to, you know, local organizations, bands to obtain the necessary approvals before they can formally proceed with their data request. So there are nuances, but you know, as a network, I think, you know, there are discussions on, you know, what more we could be doing to encourage that, you know, projects are, you know, Indigenous led and appropriately sort of meeting those local requirements.
Excellent. Thanks, Marie Chantal. We have a couple things coming in from the chat, and I hope you don't mind if I just speak your comment and question out loud. So Anne says, I noticed that many people from all vantage points in the system have difficulty understanding what is and isn't allowed under current privacy legislation and frameworks. Would the Public Advisory Council or Public Engagement Working Group consider preparing plain language material that explain this? And what are the most common reasons for delays in data access in the data access process? So that's a question for, seems like a question for Julia and a question for Marie Chantal.
So I can answer first. That's a really good point, Anne, and I can tell you that this idea of what is, you know, allowed under current privacy legislation and what isn't is a topic that comes up quite frequently, at least when I've been meeting with members of the public in our PAC. I do think that some of that would actually be addressed as we move forward with the plain language about data project, because some of those aspects about, you know, a company telling an individual, well, this is what we're going to collect, an individual would have to know, well, I know that you're allowed to collect that, or I don't think you're allowed to collect that. So I think a lot of that will come up in that project as we move forward with it. But I do wonder if there's something separate that maybe the PAC or the Public Engagement Working Group would be interested in kind of delving a little bit deeper on. So I think that's something I'll definitely take back to the group, because I do feel like it's quite an area of interest and importance, of course.
Thanks, Julia. And Marie Chantal, the other question was, what are the most common reasons for delays in the data access process?
Yeah, I think there are a few reasons. I think, you know, in the initial sort of project review, I think, you know, often sort of the data needs aren't necessarily clear. So there is, you know, some time spent, you know, discussing with the research team and obtaining input from our centers on, you know, what really is possible. And sometimes that is, you know, based on some feedback, the researchers will kind of refine their proposal, and there will be a little bit back and forth in terms of really refining their needs to make sure the project is feasible. So I think there is definitely some time there. I think in terms of, you know, sort of from the formal data access process, in some provinces, there are delays in terms of obtaining the necessary approvals, which can be lengthy. Some centers have an internal sort of governance table or, committees to review projects. Others have to obtain approvals from sort of the original data providers. In some cases, that would be sort of going to the Ministry of Health to obtain approvals. So sometimes, there are delays there. And as a network, like, we're starting to take a closer look from our the projects that are coming through us to see and better understand what are some of these causes of delays. So certainly the approvals, sometimes it could be something as simple as, there are kind of revisions that are being asked by the Ministry of Health. So sometimes it's a bit of back and forth to obtain that approval. Once approvals are in place, typically agreements would need to be in place. And that is another area where we have seen delays for a number of reasons. Sometimes it could be because of, volumes or, again, some back and forth between the researchers' legal team and the data centers or the data providers in terms of coming to the terms for the agreements. Another area where I think we're going to be looking at a little bit more closely to see what could we be doing to sort of speed up that process. One thing that we have been doing sort of as a network for a piece of work I mentioned related to bringing in sort of new data holdings is forming sort of like subgroups within our network to harmonize some of the data agreements, again, to make that process a little bit easier in terms of bringing in new data holdings. So I would say, the approvals and the agreements are probably the areas where we're seeing, the most delays. Usually sort of 1 to, I would say, 3 months on average to obtain approval, and again, around those same timelines for agreements. But we're seeing, again, there's complexity in some of the projects. And sometimes that is extending those timelines. And we're hoping that some of the work, the, sort of groundwork and building blocks that we're putting in place, connecting the people within our network are going to help reduce those delays in the longer term.
That's excellent. Thank you,
Thanks,
Marisha.
Anne, for the question.
Actually, adding to that, I mean, it seems like such a hands-on process for the DASH team, especially with the, the intake meeting and then all of that facilitation of communication back and forth. So how many, I don't know if you have this information offhand, but how many data access requests do you get every year, or whatever the appropriate timeline is, I guess?
Yeah,
Every
so
month.
since we've launched, we've received around 90, I would say, inquiries. Some of those are, more fully formed projects. Some of them are really early stages where researchers are looking just for some input from us. From those numbers, I'd have to double check exactly. I think there's around 20 projects that have progressed to the data access requests phase and are at various stages of the model. So far, we have one project that has completed and received full data for the project. We have another 5 or so projects that are in those final stages and we think might be completed in the next couple of months. So there has been, I think, also some projects where, we've supported the researchers in reviewing their project, providing some feedback, and, those teams are maybe awaiting, funding or confirmation that they're ready to proceed. So we have right now around sort of 25 projects that are active and at different stages of the model. We've actually just started putting some of those numbers on our website as well, just for transparencies. And as additional projects get completed, they'll be added to our website as well, so that the public and different stakeholders can also see the types of projects that have received data through HDRN's DASH.
Thanks, Marie Chantal. I see that Mike has a question very similar to that in the chat. So Mike, did that response answer your question? Yes, perfect. Okay. I think unless someone has any other pressing questions, I think I'm going to end it there, and maybe we can direct folks to reach out to you, Julia, or you, Marie Chantal, if you want to put your emails in the chat even, if they have any further questions. And thank you so much for joining us today. As I mentioned, the presentation will be available on our website in the coming weeks for those of you who want any links that were shared that you didn't have a chance to grab just now. And I just want to let you know that when you close this webinar, a few feedback questions will pop up on your screen immediately when you leave. So please take a minute to answer those questions if you haven't, so that we can continue to improve our free training program. And please always feel free to reach out to me as well with any questions. My email's there on this slide. And you can follow us on Facebook or visit our website to stay up to date on our upcoming training. Next Monday, January 30th, our research program, Quality of Care NL, is hosting their the first in their new series of webinars called Healthy Discussions. And Monday's discussion is about the social determinants of health, featuring Dr. Janice Fitzgerald. And our research design series also kicks off next week on February 3rd with another data relevance session about the Newfoundland and Labrador Center for Health Information, very timely, and about their provincial data lab. So stay tuned, and thank you everyone for joining us. And I see Melissa's popped a couple of things. Melissa and Marie Chantal have popped a couple of links in the chat there for folks if they're interested about the Dash Lab public engagement and the Healthy Discussions webinars that I just mentioned. Okay, have a great afternoon.
Thank you, everyone. Take care.
Thank you so much.
Bye.